Welcome to the Cognitive Informatics Seminars. Today, the talk will be by Marta KERSTEN-OERTEL, and it's on considering cognition and perception towards more intuitive surgical guidance. Marta is an associate professor of computer science and software engineering and the director of the undergraduate program at Concordia in computer science and software engineering. Her research involves developing and testing visualization, display, and interaction methods in the context of image-guided surgery. And it's really a sort of centerpiece for the kind of thing that is fundamentally cognitive informatics. Marta, it's yours.
Thank you. So first of all, thank you for having me. It's exciting to be here virtually. So actually, let me go back a second. So today, as was mentioned, I'm going to be talking about how, if we focus on not just the technology that we're developing, but also, how we should display data to the end user, and in this case, the clinician. And if we think about the interaction methods that we're introducing, then we can improve surgical workflows. We can make them more intuitive, and by doing so, we're trying to really aid surgeons in having an easier time in making decisions and treatment strategies, and ultimately our goal is really to lead to better patient outcomes. And so as the director of the Applied Perception Lab, which is the graduate lab at Concordia, we're focusing a lot more on the human-computer interaction components of technological solutions. So we're looking at how to display medical images. On what type of device? Are we going to be using a HoloLens? Are we going to be using a tablet? Or are we using the computers that are already in the operating room, or the microscopes? How do we visualize the data for the clinician so that they can understand it, so that their cognitive load is not too high, and so that they can use it in the best way possible to make the decisions they need to be making? And then also, how do we interact with the data? So actually, one of the things that shocked me when I was going into the operating room during my PhD studies was that at one point, the surgeon was there and he needed a different visualization. He needed to see something different on the computer monitor. And he actually had to call a technician, ask them to come, because there was one technician for 3 ORs, let's say, and he actually waited a few minutes for that technician to come and ask them, okay, can you rotate this, or can you put up this image? And so in terms of interaction, we're trying to think, okay, are there ways that the surgeon can interact with the systems and the images that they're seeing, so that these disruptions in workflow don't occur? And so I should say too, I think it's a really great time to be in the field, because there are so many new hardware devices. These hardwares are becoming more accessible, they're cheaper, and it's really, for example, augmented and virtual reality, owing to the gaming industry, that these technologies are becoming so accessible. And so our goal is really, let's look at these technologies, but in the context of the operating room, or in the context of different clinical tasks. And of course, the overall goal is to improve the clinical task so that there's a benefit to the patient, whether that is, a more successful surgery, a shorter amount of time in the operating room, or, there's different types of benefits. If we can benefit the surgeon, that ends up also benefiting the patient. And so let's step back a little bit and talk about what image-guided surgery, and in this context, it's neurosurgery, but you can think about, orthopedic surgery, liver surgery. Most surgeries, or maybe not most, but many surgeries now are image guided. And so what does this mean? So let's talk about navigation of cars, because this is something that we're all familiar with. And image-guided neurosurgery is also called neuronavigation. And so we can talk about navigations in our cars. And if you think about it, what happened, 20, 30 years ago, the way that we navigated, say you were driving around Europe, or you needed to drive, to a part in the city that you were not familiar with, well, what you would do is you would have a paper map on a 2D paper map that looked like this on the left here. And then you would have to map the real world, you or your passenger would have to map the real world that you were seeing, so all these streets, to where your car might be on this map and how you would then proceed to your destination. And as you can imagine, registering the real world to this map is quite a difficult task. And, I can remember my parents getting into arguments and my dad being like, here, you navigate me. And it's really not that easy to, map a 2D image to the 3D world. So luckily for those of us who this was a difficult task, about 15, 20 years ago, maybe GPS navigation systems started becoming popular. And so with the GPS navigation system, what's happening? You have satellites in the sky that are mapping the location of your car. And then you see your car as this little triangle on a map, and you know where you are. So that mapping of location of your car to the city, to the province is done for you. And so it's a lot easier than to know, okay, I'm supposed to turn here, I'm supposed to turn there, because you don't have this need to map it. It's already done. And then, so the thing with this type of navigation, though, that people were doing, though, is that you were looking towards a separate device. And before that used to be, your Garmin your Garmin Navigator, or now it's, Google Maps on your phone. And BMW was the first ones to take this a bit further. They said, okay, these focus shifts between this device and the road, maybe they're not optimal. And actually it's been shown that focus shifts can be detrimental to the task at hand. And so what they decided to do was to have what fighter pilots have. So a heads-up display showing the information that people need to navigate. And so it's essentially what it is it's that information is projected into your windshield, and you no longer have to look between the road in front of you and the device on the side. And so if we think about image-guided neurosurgery now, and this is where I should just forewarn people that there will be brain images. I will try to, actually, I can't see what the next slide is, but hopefully that's okay. So if we think about now, if we turn to image-guided neurosurgery, the evolution of navigation is very similar. So before, surgeons and clinicians used to look at 2D planar images, and they would have to map that to a real patient, so a real 3D patient that's on their operating room table. And this is actually quite a difficult task. And it's made more difficult because the patient is draped and you don't have landmarks that you can say, okay, this is the nose, this is the ear. And now if I look at my image, this is this. What you see is this little part of, in our case, the brain. And so as one surgeon put it, the head, the skull, the skin, they don't show you where a tumor is or where an aneurysm is. And so what surgeons would have to do is that they would make a larger opening in the skull, so it was less minimally invasive, more intrusive to the patient, and then they would, try to get to that tumor or to the aneurysm or whatever disease was happening, and they would refer back to the images. And again, it wasn't the ideal situation. What happened next was image-guided surgery. So over the last several decades, surgeons have been using image-guided surgery, and this is very similar to actually your navigation system in the car. So in image-guided surgery, you introduce a camera, and it's an infrared camera, into the operating room, and you have tools that are tracked. And so then when you see your tool, you can see the pointer of the tip of your tool with respect to the patient images on a computer monitor. And so that's exactly the same as seeing your car on, on Google Maps or on Waze. And so this really allowed for so that mapping that's done for them really allowed for more minimally invasive procedures and really simplified things for surgeons. So then, so here's just an image of this being used in the operating room. So we have a surgeon who is using a pointer, and then he sees the pointer, the pointer location on the computer screen in the operating room, and then that mapping is done for them. So, but this brings us back to maybe a small shortcoming, the same one we have with the navigation systems. So here you actually have 4 people who are looking at a computer monitor and no one is looking at the patient. And so there's this, again, there's this need to, okay, I need my guidance images, they're here, and they're actually quite far because they have to be out of the sterile zone of the surgeon. And then I'm working here. Okay, wait, now I have to look here, now I have to work here. And so there's this disruption in the workflow and this change of focus shifts, which is, you know, surgeons are very used to this, but it doesn't mean that it's not ideal. I mean, sorry, it doesn't mean that it's ideal. So the motivation of most of my research is really, how do we solve this disconnect between where the surgeon is looking and where they're working? How do we visualize the complex images that they need to look at? So now we have the ability not to just have 2D scans, but we can see them in 3D. But if we see them in 3D, we're still looking at a 2D monitor. So how do we give them the spatial information and the depth information that they need in order to be able to best understand the medical images? And the medical images can be CTs, angiographies, MRI, or so on. And then lastly, how do we improve the surgical workflows, especially when the surgeon is using novel tools and technologies? So if we're bringing something into the OR, are we going to improve the surgical workflow, or is there a reason that we're disrupting it? And so these are the things that we really need to think about when we're bringing new technologies into the OR to either improve things or make them better. Improve things, sorry, and make them better, not or. So before I dive into some of the main projects, like a few details of the main projects we've worked on, here's a kind of overview of what we're looking at. So similar to BMW, we're looking at how we can bring augmented reality into the operating room. We're developing we're using tablets and smartphones and seeing how those can be brought into the OR. And we've also started looking at how we can use virtual reality for surgical planning. In terms
Marta,
of
everybody knows what AR and VR is, but believe it or not, this is not a medical group. They don't know what OR is. That's operating room.
Yes, operating room, sorry.
Okay.
Yes, yeah, please do interrupt me at any time. Yeah, sorry, yes, the OR is the operating room. Okay, so we're looking at these things in terms of visualizations. We're looking at how to improve spatial understanding of complex medical images. And we're also looking at, actually this came about a little bit from the pandemic and the fact that often our end users, there's few of them. So if I think about, how many neurosurgeons are at the neuro, it's less than a dozen. And so it's really hard to do experiments to try to figure out how well something is working with your expert users. And so what we've been looking at also is to develop games and using gamification essentially in order to get some psychophysical evaluations of different visualization methods. So these can be distributed, you can download them on Google Play or on the iPhone, and then anyone in the world can kind of run our studies. And then we try to make them fun so that people actually do run the studies. And then we've been looking at interaction. So I'll talk about, actually, I think all of these today. We've used gestures on the tablet. So I mentioned interaction is something that surgeons don't actually usually have. They have to relay the information to a technician, and that can be problematic just because they're not necessarily speaking the same language. They have different expertise and so on. And so trying to give, a bit of that control back to the surgeon. By allowing them either to interact with gestures on the tablet or use the surgical pointer to interact with the image-guided surgery system. And then we've also looked at sonification in surgical target localization, and I'll talk in detail about that project. And lastly, I just want to mention, we're really want qualitative feedback in the operating room. And sorry, we have been getting qualitative feedback in the operating room, but we also want to try to get more physiological measures. So we've looked at using EEG, and we're starting to look at using eye tracking as well. And so so I see that there's things in the chat, but it's hard for me to navigate to that. So just interrupt me if there are questions.
Okay, either the person can interrupt directly if you're not shy, or I can say it for them. And
yes,
I think Mao's is a question for you at this point. How do you handle delay and jitteriness of the tools?
Yes, so that is a very good question. The cameras are actually very, they're high frequency cameras, I think 120 hertz. So you don't necessarily get any jitterness if you're using the high-end commercial tools. That being said, when we started developing our own tools, we have seen, delays and jitteriness, especially when we use the iPad and things like that, which is not as accurate. And so we don't handle that well, although there are computational ways to do it. So for example, Kalman filtering it so it looks smoother and not as jittery, but the commercial systems don't, there's no delay that is visible to the surgeon. And I should also mention, because this brings up a good point, that they're not constantly relying on this information, right? They do a bit of surgery. They might not know exactly where to dissect next or where the edge of the tumor might be. Then they use the navigation system for a little while, then they turn it off. So they're going back and forth. Yeah. So I was able to pop up the chat. So I'll be able to answer questions as they come up as well. So then our solution has really been, how can we facilitate tasks that are really complex? Like surgeons are doing complex tasks that require a lot of thinking, a lot of concentration. And how can we facilitate these tasks? And how can we do so in a way that blends into the surgical workflow in order to improve surgical outcomes and patient care? So as I mentioned, one of our focuses, and this is a little bit earlier on research, but it's kind of near and dear to my heart, because as I mentioned, when I was doing an art history degree, and we were looking at, how art evolved from these 2D planar images in the Gothic area where you didn't have perspective cues, and then somewhere in the Renaissance, you started having these perceptions, and artists started working with different ways to show perspective. And so this was something that I was like, okay, well, we need the same with other types of computer generated images. And so in the context, I looked at this in the context of orthopedic surgery when I was doing my master's. And then when I started my PhD, I started working with neurosurgeons, and these are actually very complex images. So these are, for neurovascular surgery, what you're looking at is all the vessels of the brain. And there's a lot, and they're very complex. And so in neurovascular surgery, you have these images. And just to give you why you would be doing neurovascular surgery, so if you need to clip an aneurysm because it has the possibility to hemorrhage, or for arterial venous malformation. So these are these complex bundles of vessels in the brain that might, again, they have weakened walls, so they might bleed, and they sometimes require surgical interventions, or arterial venous fistulas, where again, you have abnormalities in the vessels of the brain. And so this is a CT angiography image. And as you can see, it is, if I show you this, it's actually quite hard to say, okay, is this the back? Is this the front? The vessels are overlapping. I don't know exactly how they're overlapping. And of course, domain knowledge would help. However, maybe in surgery, you don't need that, or you want to have intuitive visualizations. And the other thing too is that the perception is made more difficult because even you can't, if you're talking about an anomaly, like an arterial venous malformation, well, then you might not be able necessarily to rely on previous knowledge. And that's especially hard for novices and medical students to spatially understand these types of angiography images. And then there's some kind of cues that you can't really use. So traditionally, we don't use perspective projection because perspective projection, essentially, your angles get distorted. And if you want to measure the distance between two vessels, then you can't do that. And so there's a number of cues and things that make it difficult to understand these images. But there are other types of perceptual cues that we can add to help. So here, I mean, this is very simple. This is the raw scan, well, 3D rendered raw scan. If I add a little bit of edges, then I start to say, okay, actually now I can see that the sinus, I'm looking from the back of the head, I see the sinuses, I see that, you know, certain vessels are overlapping and I can tell which ones are closer to me. It's not perfect, but it's already better than the image I showed before. So by adding these simple depth cues to these volumes, we can really improve the spatial understanding of them, and especially in terms of which vessel is in front. And so this was some of my initial work during my PhD, actually. So I wanted to look at what are the best cues to look at these images. And so we looked at things like adding edges, which I just showed, chroma depth, where this is actually pseudo chroma depth, but chroma depth, you essentially go through the visible light spectrum. So from blue, green, yellow, orange, red, and things that are blue are far away and things that are red are near. And this is just a typical way to encode depth in a single image. And it's been shown that pseudochroma depth is a little bit better for vascular visualization. So we looked at pseudochroma depth. We looked at aerial perspective or fog. So think of yourself on top of a mountain. Things that are far away are really hazy. Same thing, if you make things that are far away from the viewer hazy, then well, if you've played video games, if you have fog, you know that that's a very effective cue. Motion is another one that can be used, and of course stereo. So this requires putting on stereo glasses. And we did a number of experiments, both with novices, looking at each of these cues, and with the experts. So the experts being either neurosurgeons or neurosurgical residents. And we present these cues, and we found that, you know, for novices, pseudo chroma depth, fog, and edges were actually very effective cues, with chroma depth being the best one. And so that would have been great, but I was so happy that we actually then went and did the same experiment with surgeons, and they told us, well, chroma depth is completely unintuitive, because in medical image visualization, if you think about Grey's Anatomy, what you see is veins are blue and arteries are red. So they were thinking, okay, that's how I'm used to using it. Why are you using the same kind of colors to represent depth? And then as well as looking at, so the task of these studies was very simple. You just had to determine there was 2 indicated vessels in these complex scans, and you had to indicate which one was closer. And as well as looking at, you know, how well they did, we also looked at how fast these cues were, because you want to make sure, again, you don't want to burden surgeons with this information. You want them to be able to understand very quickly what they're trying to see, and which vessel is in front, how the spatial, you know, and the anatomy is in terms of spatial, in terms of the spatial representation of the different vessels. And so now that we had a good idea, okay, we know that fog works well and that edges really work well for surgeons. So we wanted to then say, okay, well, one of the problems in augmented reality, and let me show you this image, is that whenever you combine a virtual element with the real world, the virtual element will always look like it's floating above. And that's okay if you're playing Pokemon Go. It's fine that, you know, it doesn't really matter where that Pokemon is, or if you're playing a video game. But if I'm bringing this technology into the operating room, well, I don't want the tumor to look like it's floating above the surface of the brain. And so this was our first issue. And we thought, okay, 1, how can we fix that? And 2, you know, how can we bring those previous studies that we saw, okay, these are the best way to visualize the data into an augmented reality setting? And so the first way that we realized okay, if I have the real world and I have my virtual element, we have augmented reality, right? We have a virtual element and we're combining it with the real world. Then if I actually keep features from the real world on top of my virtual element, then I can make it look like I can start to have the proper depth perception. And this is essentially what you have to do. And hold on, I think I messed the order of these slides. So this was essentially what we did. I mean, the details here are not important, but we're essentially taking the image of the real world, we're doing some processing on it to keep the edges in order to make the augmented reality view much more realistic. And then, as I mentioned, we started looking at, okay, we had all these chroma depth, fog, edges, we have those studies, do they also work in augmented reality? And so we started looking, we did a lot of work on which visualizations are most effective. And once we did that, okay, we thought we had a great, we thought, okay, we know that edges work really well. We're going to use fog. We're going to do color coding, but not the color coding that that confuses the surgeons. We're going to keep, and then we brought, we had done all these experiments, sorry for flipping back and forth, in the lab, right? And we did them on a 3D printed head. And we brought this into the OR and we realized nothing worked. So the first time I went into the OR, we realized that the edge extraction of the real world didn't work because the OR lights were so bright that we were extracting so many like highlights and vascular images that there were so many edges you couldn't see the virtual object. We realized that showing red on the patient was the surgeon couldn't see any of the augmented reality view. So we needed to use bright color, like we couldn't use red anymore. And so there was a lot of things that, just to say that research fails and those failures you learn from. So it was really disappointing the first few times in the OR, but we kept adapting based on what was happening in the OR. And of course, when you're asking surgeons to use a new technology, it was frustrating. But we took everything they said and kept adapting our system so that things would work properly. And so here's a case where, actually, maybe I'll just, can I pause this here? So I just want to, actually, no, that's fine. Let me show you this. Let me just explain this video before I show it to you. So as I said, we started bringing it in and we started getting positive feedback from the surgeons. And we wanted them to say, okay, how can we evaluate this? And one of the things we decided was, since it was such a new technology at the time, we said, okay, we're going to have the surgeons use it when they want to use it, and then they can tell us when it's useful. And so one of the things we realized that it was very useful for was craniotomy planning. So what is craniotomy planning? So you have the patient, they're lying on the operating room table, and you need to access a tumor, a vessel in the brain. And so you need to know where to actually remove a part of the skull and open the dura. And so what the surgeons really liked was that they could either walk around the patient and see the anatomy of interest below the surface, while whether they were using a tablet or looking at kind of the image-guided surgery system. And then the other thing too is the mapping was done for them. So what they could do is they could just outline certain things by having that virtual reality, virtual element, virtual anatomy in their augmented reality view. So I'll show you an example of this. So this is craniotomy planning. The first one is without, they're sped up, but the first one is with the traditional system. So they're looking at a monitor, they're trying to figure out where the doc goes, and they're outlining this tumor. With the AR overlay, well, they have all the information combined in one image because they know where the tumor is. So then they can just outline the tumor, and then, based on the outline of the tumor is where they decide to put burr holes and remove part of the brain. The other thing we realized was that the surgeon, when we give surgeons, so one of the things I mentioned is it's nice to give surgeons control. And so if we allow the surgeon to control the augmented reality view, they get a much better spatial understanding of how things lie, and they can control it as in the beginning of the video with the surgical pointer, or they can even move the camera around. At this point, I should mention the augmented reality view was still on the workstation. So it wasn't, they weren't wearing AR goggles or having a tablet yet, as this was quite a bit earlier research. And so this motion really helped. Okay. There we go. And so based on, as I mentioned, we decided, okay, we're going to keep bringing this into the OR. And what we found was surgeons really liked it on the skin before they even, cut into the skin. They really liked it, as I mentioned, to kind of talk to the resident or talk to the, whoever's in the OR, say, okay, here's the vessels, here's how they lie. How are we going to, approach this case? So then on the dura, which is this membrane under the skull, they also used it a lot. So they, okay, I'm going to start resecting here, as well as on the cortex. And in the last image here, for planning resection. So one of the things that the surgeons, one of the things we're able to do with virtual reality is the surgeon knew that they had to get to a certain vessel first. And so they asked us to put a virtual pointer on that vessel, a virtual dot essentially on that vessel. That's the pink dot you see. They looked at that AR view in the surgery. They put a micro lentil, which is this little pad on that dot. And, then they decided, okay, I need to get there. How am I going to resect down to that vessel? The other thing with virtual reality, again, we can change the colors. So in arterial venous malformations, one of the things that the surgeons liked were, okay, can you color code this? Like the veins are blue, the vessels are pink. Again, we weren't able to use red for obvious reasons. And they said, I just want to be able to differentiate between them in the AR view, especially when they're like intertwining and, there's a malformation and it's hard for me to tell which one's which. And then other things we looked at was also showing them flow information. So these images here, they're showing them essentially some flow information in the augmented reality view. And then before I move on, one of the things that I should mention is that once the surgeon starts working, so I showed you different points in time when they found AR useful, but once the surgery starts and things start moving too much, what happens is that the surgeon can no longer rely, like everything, the preoperative images, the MRI or the CT or the angiography that were taken before, they no longer match what's happening in the operating room because things have moved, because they've moved brain tissue, they've even maybe taken them out of some tumor, they've cauterized. And so one of the things that we were exploring too was, okay, can we use this was done before. Ultrasound can be used to update those MRI images or those CT images so that they still reflect what's happening in the OR. And so we said, okay, well, why don't we combine ultrasound and augmented reality so that our augmented reality view is still accurate? And so that's one of the more recent works and something that we're continuing on now. Okay, so as I mentioned, all of that still was on the operating room monitor outside of the sterile zone. So in the image I showed you where there were the 4 people in the OR and they were all looking at the monitor. So we had solved the problem of the mapping by giving them an augmented reality view on the monitor, but we hadn't solved the problem of focus shifts. And so now we really wanted to look at, okay, our focus shifts are really big issues. Do we need to think about them? And so we did a study in the lab in this case where we thought, okay, our original hypothesis was if I have the augmented reality view in front of me, then I'm going to be quicker, I'm going to be more accurate than if I have to shift back and forth. So we wanted to test that. I thought it was a good theory, but we wanted to test it. And so we had 3 different systems. We had the traditional image-guided surgery system where there's no augmented reality view. We had the augmented reality view on the image-guided neurosurgery system, so the computer outside of the sterile zone. And then we had a phone that was showing the augmented reality view, and this was between the user and the patient. And I showed you the videos of the craniotomy planning. So we did the same thing, again, in a laboratory setting. We essentially had people to plan a craniotomy based on tumor images. Oh, so here are the 3 systems, the traditional, the desktop, and the AR. They had 4 different tumors they had to outline in each of the systems, essentially. And we, of course, randomized the order and then asked them a number of questions and also looked at accuracy and time. And so what we found was that the number of attention shifts is significantly reduced with augmented reality versus traditional navigation. So that's for sure. But what was surprising to us was that there was not much difference between the desktop version of augmented reality than the mobile version of augmented reality. So that's whether your AR is kind of over here and you're working here, or whether your AR is straight in front of you. Similarly, in terms of time, we found that, yes, there was a big difference between traditional navigation and desktop augmented reality, but there wasn't much difference between the mobile, or there was no significant difference actually between the mobile and the desktop augmented reality. That being said, if you ask the users which one they prefer and which one they were more confident, so this, I mean, we just used a NASA TLX, where you're looking at different measures such as mental, physical, temporal effort and frustration. And users were more confident with augmented reality. They felt more accurate with augmented reality, thought it was more intuitive, thought that it required less effort in terms of cognitive load, but they also preferred the mobile augmented reality than the desktop. So that being said, we thought, okay, well, even if there's not a huge difference, this is still an important avenue of work. And we still thought, you know, allowing the surgeon to have this tablet that they can use, or we moved to a tablet that they can use instead of having everything on the side, is a really valid area of research. And so we developed Marin. So this is Marin. It's called the Mobile Augmented Reality Interactive Neuronavigator. Which I think it was just, well, the pandemic makes it feel like it was a long time ago, but it was actually only in 2020 that we developed and tested this. And compared to other systems, so here, this is definitely an area of future work. I think and again, I mean, obviously I did the study not as a participant, but, and I think there's certain sounds like that it's easy to navigate, to use, and you don't need that visual situation. But as someone who's somewhat tone deaf, like some of them, I was just like, I have no idea which direction to move. I don't have a good inclination there. So it was very, I think there are situations where it can work well, and where you can look at the patient, you already have some spatial information, but you need that sound for some other type of information.
Could you say explicitly how was intensity and frequency used? Because if you're tone deaf, frequency doesn't help you, but intensity is still there.
Yes. So again, for me, so I don't remember exactly the details of the implementation. I might be able pull up some videos, but so I think this is why the signal to the noise to signal worked really well, because everyone can hear, and then you can, and also the backup beeping camera and binaural beat, I think it's called, actually the pulse tone sonification worked really well compared to trying to match pitches or frequencies, which, you know, the musicians were really good at this and the rest of us were not. And then in terms of distance, the audio visual also, if I was, you know, because we said you have 15 seconds, get as close as you can. You know, we didn't let them continue on forever. And so for audio visual, they were able to get the closest to the target, and that was a significant effect. And then, as I mentioned, there was evidence that the signal to noise sonifications may be better for increasing target localization accuracy, and the audio visual feedback resulted in terms of ease of use of the subjects. This is what they thought was the easiest to do if they had both audio and visual. And again, you know, having done this, I think you can, for the audio visual, you have a really good idea of where in 2D space you are. And so all you need to do is then use that audio sound to help you navigate into the 3D. So I think this was really, it's a very nice combination of audio and visual. Okay, so that being said, so the last thing I said here was the perceived ease of use. You know, how I felt, what was easiest was always qualitative data. You know, we asked them to rank it. We asked the subject, okay, what was the easiest, and so on. And this is very typical of research studies, and essentially everything that I've showed you today to now, whether it was, you know, how do we visualize AR, it was always a questionnaire at the end, as well as some task-related performance measures, so time and accuracy, for example. And then we always ask them, you know, in a post-test questionnaire, some subjective measures such as, you know, doing the NASA TLS or Likert, and subjective ratings, you know, on perceived effort or cognitive workload might not be the best way to evaluate it, because I might think, oh, I've done this really well, so it was easy. But that might not be the case. It might be, you know, I've done this really well, but it was actually hard doing it. It's just I had the information. And so this is something that we wanted to look at next, especially with the advent of, oh, that's an old slide. Okay, that's okay. Especially with the advent of all of these kind of commercial low-cost systems like EEG, GSR, all of these things that used to be really medical grade, we can now use them in the we can use them now at you know, very low costs. And so we had a number of hypotheses. Essentially, we thought audio information would improve the ability to locate points within a 3D volume. So essentially what they were doing before in terms of accuracy. Tasks using audio-visual feedback would require less cognitive workload. And we thought we would see that both in subjective measures as well as physiological measures. So we thought, okay, we saw that audio-visual, people like this the most. So we think that that requires less cognitive load, and we'll see that both on EEG as well as in their ratings. And then rather than if they only have sound or if they only have visual information. And then we thought that the subjective and physiological measures would be positively correlated. So if I think something is hard, my cognitive load on my EEG is going to look higher. If I think something is easy, my cognitive load will look lower, essentially. And so we replicated the study we had done, which I just presented. And we had 13 participants navigate the tracked surgical pointer. So here, I don't know if you see my mouse, but you have the pointer, you have this 3D space, and they did 24 trials, again, visual, oral, or both visual. And in this case, we only looked at signal to noise, just because this one was the one that, you know, we saw had worked best for participants in our previous study. And then we recorded the participants' cognitive load using a Muse headset using relative alpha band weighting. And so the Muse, I mean, it's not your fanciest EEG headset, but there was previous research to show that it does correlate well, at least with certain measures, and you typically with it can do a pretty good job of alpha measures. And so it has essentially 5 sensors on the forehead, 2 behind the ears, and then 3 reference sensors. And after the study, we also gave the participants a NASA TLX questionnaire that they filled out on each of the different modalities. Oh, here's another. Oh, I don't know where that came from. Okay, so what did we find? Well, first of all, we did find a significant effect of condition. So yes, again, audio-visual allowed them to get the closest to the target. And we found the difference between audio and audio-visual conditions was skewed in the predicted direction, but not significant. So visual, people still did well with visual, even though they did slightly better with audio-visual. In terms of cognitive load, so again, we use the EEG metric alpha band change relative to theta, delta, and gamma. And we calculate the average physiological working cognitive load across the entire 15-second trial. So this is roughly about 300 data points per trial. And then we did an ANOVA, and we found a significant difference between the audio and the audio-visual condition, whereas the difference between the visual and the audio-visual condition was not significant. So again, visual is harder, or requires, sorry, not visual, audio has a higher cognitive load compared to audio-visual trials, but there was no difference between audio-visual and visual alone. And then again, we wanted to explore the efficacy of basic EEG recordings as a marker of cognitive working load. And I think this is just interesting, not necessarily for this study, but in terms of general human-computer interaction research. So we looked at the correlation between the collected EEG data and the results from the NASA TLX questionnaire. And we compared the average EEG measurement across all trials against the average TLX scores on a per person basis. We plotted these, and this is what you see here. And we found no significant correlation between the physiological measures of the cognitive workload. However, I guess this isn't necessarily, I think, the end all and be all. Maybe it's not surprising. I think there's a lot of things here that need to be studied more. One, it was a small amount of participants, so maybe there is more information that we're just, and we did not have enough participants. It could also be that our EEG signals, it would be nice to do this with a medical grade device and see how well it correlates in a more simplistic study. So I think this is definitely something for future work that, as I mentioned, I'd love to get a student to work on. And that kind of, yeah, so that brings me to my future work. So one of the things, again, is looking at cognitive load from using physiological measures. I think also looking at stress in the operating room. So things like bringing in eye tracking, cognitive load, and even GSR, and also looking at, when these measures, what's happening in the OR when these measures change. And I think one of the things I'm also interested in is looking at cognitive load when we're introducing augmented reality, using augmented reality displays, because I mean, some surgeons have been very keen on it. Other surgeons have said, I don't understand what I'm seeing, what you're showing me, and we've had to explain it. So it would be good to know, once they're explained, once they're used to this, how is it impacting their workload, essentially? And is it beneficial, not just in terms of helping them make decisions, but also in terms of, looking at cognitive load. And we're also looking at working towards trackerless navigation. So I mentioned those fancy cameras. We want to be able to do some navigations just with the iPad and low-cost tools, so that we could make this more accessible, not just to kind of hospitals in the Western world, but also hospitals that don't have the potential for image-guided neurosurgery systems or fancy systems. Yeah, and of course, a lot of the things were tested so far in the laboratory, and of course we brought a lot into the OR prior to the pandemic, but we're hoping to do a lot more of that if this ever ends. So that's it. I just should show all of the students who have been working hard on all of this, and funding, as well as, of course, our collaborators. Most of the work has been done at the Neuro so far. So thank you.
Marta, thank you so much for a wonderful presentation.